This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
I'm joining the direct primary care movement. It's to practice medicine the way I was trained, not be held back by hospital systems or insurance limitations. I'm Dr. William Steelman, and I run the Steelman Medical Group, and this is my DPC story.
Dr. William Steelman was born in Virginia Beach. Son to a U.S. Navy family, he moved along the eastern seaboard until finally settling in Ocean Springs, Mississippi. He attended Millsaps College in Jackson, Mississippi, graduating with a BS in chemistry before heading to graduate school in pharmacology and toxicology, and then finally osteopathic medical school at Kansas City University of Medicine and Biosciences. He completed his internal medicine residency in York, Pennsylvania, and moved on independently to gain as much experience from as many mentors as possible. Dr. Steelman has done extensive work in the hospital and medical office setting, and after more than 12 years in practice, has now opened the doors of Steelman Medical Group, a dream years in the making. When laying the foundation for Steelman Medical Group, he desired to create an organization that didn't face the unnecessary burdens of government and insurance. His goal is to focus only on his patients and their needs. Dr. Steelman and his wife, Mallory, live and work in the Woodlands, Texas. They have 3 beautiful daughters, Paige, Presley, and Charlotte. Welcome to the podcast, Dr. Steelman.
Thank you. It's nice to be here.
When you applied to be on the podcast, you had just opened days before. So I think that this is wonderful. And I think about Dr. Jade Norris, when her episode re-aired, she messaged me and she said, gosh, so much has changed. And so I love this. This is a little time capsule of your story and your practice. And I can't wait to see what happens for Steelman Medical Group and yourself in the future.
Thank you. Yeah, we just had our ribbon cutting January 5th, opened our doors, and I've started taking patients in, doing initial interviews, and it's gone amazing, I would say.
That is fantastic to hear. So one of the things that I was very drawn to was a fact that you had put on your website. And that fact was based on research done by Merritt Hawkins that summarized that in the state of American healthcare, there's been a significant increase in the delay to get in to see your physician in this country because of the way that our healthcare system is developed. And so I want to ask, when you look back on your journey and training and your medical school training, your residency training, did you have a sense that this trend of delay in getting access to care was happening?
Oh yeah. That it really goes back to just working as a hospitalist. This is my 12th year doing that straight. I started seeing people, and this was something I didn't expect to see first starting off, because I came from a small town where my original mentors operated a small clinic, and we went back and forth between the clinic and the hospital. So when I saw you in the hospital in the ER, guess what? I saw you every day after that. It wasn't just a residency clinic, it was the way they operated their office. You never had to worry about a patient not knowing what their medication was and then just not taking it. The continuity just disappeared all of a sudden, just from what I was seeing. And my comment that really started this whole thing was, if I had just seen people 4 days before I had met them in the ER, I would have prevented this entire visit.
It's just so crazy how that is an ugly truth that so many of us are realizing. And the reason I asked about when did you notice this trend is because I think about my experience and I didn't realize it truly until I was practicing outside of residency. But now I have residents contacting me about, I'm so frustrated because of said delay in care, because of, if I could have seen them 4 days prior, I could have also prevented them from going to the emergency room. I think I've mentioned it on the podcast before, but there was a delay in care for a patient who joined my practice where they had a hematoma that eventually went septic because they couldn't get in for a month.
Right.
To their former primary care physician or non-physician provider. I don't actually know which. And it's you're speaking to the soul of why we're in this movement. So when you talk about this delay in care, for those people who are like, that's not necessarily what's happening in my neck of the woods, which if that's the environment you're in, please go to the contact page on my DPC story and apply to be a guest because I want to hear all the stories. But for you, when you talk about that, if I could have seen you 4 days prior, what are some of the things that you saw that were ridiculously avoidable because of this delay in care?
Most of it was things that I would have considered to be text or a phone call fixable. Okay. We're talking thousands of dollars in emergency care, thousands of dollars in medications that were unnecessary, imaging that never needed to be run to verify things that we do as a defensive practice in the hospital, but really it's just a protocol driven thing. So it would be something along the lines of, I went home and I took my antibiotic for 1 day and I wasn't feeling better, so I came back. I said, well, do you have a primary care physician? No. And I don't know if it makes any sense, but I live in an area with abundance, let's say. Okay. And it made no sense to me that I could have people who I could easily coach through this in 30 seconds, but they were unable to interact with me after the fact or even before they came into the hospital. I guess that might step back a little bit into my training, where I trained in Pennsylvania, a little rural town outside of Philadelphia. The small hospital didn't have specialists, and it was next to a larger system that dominated most of the specialty care, and we took care of our bit, right? The two populations didn't really intermingle for the most part. They were loyal to one side or the other, like a lot of small towns. But the thing about my training that really stuck out, and I've seen a lot of different hospital systems. I think I'm up to 12 hospital systems now. But the thing that stuck out about my particular training was my mentors would give their cell phone out to their patients. They would talk to these people like they were family or friends, and they would see them however often they needed to see them. And so I think it was almost DPC before that was a thing. I think that's just the way it was because it was such a small town that they knew these people and they knew their relatives and they had been following them for decades. So it really became like that for me. And I thought it was very strange as I stepped out into the world to get a lot more diverse experience that suddenly I'm in a fee for service, insurance driven world that's 7-minute interactions. And there's huge barriers to me having any follow up or interaction with these people again. And it made no sense to me as an internist, as a physician, just to treat in street, to do this prescription and be done thing just didn't make any sense at all.
That treat in street. I know that there's people listening who've heard that before,
Yeah.
and it is absolutely disgusting and it is absolutely rampant in our medical care. You think about especially hospital work, social workers, diabetic educators, lactation consultants, hospitalists, everyone is got to get them in, got to get them out. If you have a vaginal delivery, fantastic. You're going to go home in 24 hours because this is not the 1930s anymore. It's so silly, but it also speaks to how what medical students and residents see truly matters. I think that is one thing where I look back at, if I were to have stayed at the fee-for-service, hospital-driven, family-based medicine practices for residency, observing or shadowing, I would never never have understood the value of being a full scope primary care physician if I hadn't gone to Nebraska. Can you imagine if you had never seen a doctor hand out their cell phone? I mean, that's so small town, but it's also, you don't have to be in a small town to achieve that level of personable care, which you are doing now as a DPC doctor. So let me ask you, when we talk about residency and you saw the way that small town medicine was done and how personable it was, were you ever encouraged to start your own practice or to learn about the business of medicine so that you could do the same model after residency?
I guess like anything, anywhere I've been in my career, just going back, I was originally a bench scientist. I was pharmacology and toxicology before medical school, and I decided PhD life wasn't for me. Cancer cell research and animal research, just it didn't have the same passion for me. So when I made the decision going into medicine, I really wanted to interact with people in a better way than what I was being limited to. When I was training, the primary concern at the time was Affordable Care Act. So that had just come out maybe my third year or so. And I immediately saw a huge influx of people who had never had access before. So this was a thing that was new for all of us. And I thought it was exciting because we get all kinds of new pathology. I was excited as a resident. But the focus of my mentors, and I would say most of the training, wasn't on the entrepreneurial side. It wasn't on the business side. It was on the billing side. And we were all trained to be good little billers and to maximize our CPT and DRG and all these acronyms. It was a game, and you had to get good at the game to survive in the outside world. And I would say that did pay off. From being a hospitalist for 12 years, it was nice to know a way to code the way that everyone wanted you to do it, and got you less phone calls from the insurance people. So, yeah.
Gotcha. Now, your journey to where you are geographically in the woodlands of Texas, I want to ask because you had this 12-year experience of being a hospitalist, but you weren't just a hospitalist in one hospital that whole time. So can you share about what was it that drove you to be a hospitalist in the way that you were working in different hospitals before you came to the woodlands?
Sure. When I trained, it was in a smaller hospital. I think I want to say we only had about 30 beds. It was not very large. There was not very advanced technology there. Very old school in terms of putting things together. We used to joke about using paper clips and coconuts to fix everything, but it was more modern than that. But the truth was that I wanted more. I wanted to see it all. I didn't get that downtown experience the same way some of my peers had. I didn't see all the newest, latest technology. You just don't know what you don't know. When I got out, immediately I just took as many different travel locum tenens jobs as I could. And of course, there were places I interviewed that wanted to sign me up as a perm doc as a hospitalist because it's an in-demand position. But nothing ever really had the same setup where I was a traditional doc in a clinic following with chronic patients. And what I said to myself at the time was, how can I really increase my skill set? How can I start to do things beyond the basics and the fundamentals if I don't ever see it? So I had to go see everything.
It speaks to a true primary care focused doc. Like,
Yeah.
it's really important to see all sorts of things. Like, I'm very grateful for my time in residency because our hospital was the hospital of pathology. Our hospital was if you're a doctor, you and your family want to go to the hospital that we trained at because that's where the doctors are the most exposed to everything. And that's from good to bad. So I think that's totally reasonable. Now, what was it that in the last 6 years made you stay in the woodlands?
It was a funny story. Of course, when I left residency, I was single and I moved to Texas because my brother lived here for about 10 years beforehand. And he said, look, man, you're not meeting anybody because you're in a small town. You just need to come to the big pond here in Houston. We're the fourth largest city in the US. You're going to meet somebody here. And sure enough, I met my wife the first day of my interview when I moved down here. Yeah, very cute story, but it turned out wonderful. And the position I picked up just sort of out of the blue turned out to be a good experience for me. So
High five to your brother for that
Yeah,
really
right.
amazing tip. Yeah. So now let me ask, when did you start thinking about leaving that system to go towards the DPC model that you're in now?
Originally, it started with when I moved here. It really wasn't all that different. When I worked as a locum doctor traveling, I was on the road 6 years. I didn't even own a couch until I was 32. I would really stretch that out quite a bit, and I don't know if that how much of that is me and how much of that was just the circumstance. But when I finally decided to settle down into one spot, I met my wife. We have a beautiful family now, and the thing that struck me was I missed having some continuity with the patients, having some accountability, having the ability to really make a profound difference to them in a way that I missed from my training. The barriers to even interacting with a hospitalist after the fact are so huge. And you can get me started on Epic and all that, but it's very difficult. And I missed that back and forth. The hey, tell me how this works out. You would sign your discharge papers and then you would never see them again. And people were getting problems because they were asking their specialists to act like primary care physicians. And I still see that today. I still see that all the time. In fact, most of my patients signing up are doing that. And I wouldn't say it's as universally effective to do that.
Well, it's totally not. It's when you're a physician and you have a specialty of family medicine, a specialty of vascular surgery, they're different things that you're going to be doing every day. One of my dearest friends, who is a vascular surgeon, I would read his notes and I'm like, what's this whole primary care situation over here? And his explanation was, well, they don't have a primary. So I don't have anyone else to do it for them. So I have to do it myself, which is amazing. But this physician was also asking me, like, how do you treat vitamin D deficiency? Things that you wouldn't necessarily see in vascular surgery. And it's not about you have to stay in your own lane, but it's about patient care and how do we get patients access to quality care. And that is definitely not the solution to have a person who doesn't do primary care on the daily be responsible for primary care plus said non-primary care specialty. And it's crazy that a lot of people who are listening have patients who that's been their status quo, to have their specialists take care of primary care because they didn't have access to quality primary care or there was major delays in accessing that primary care. All that said, when you realized that you wanted continuity, at what point did you decide to do DPC versus open your own clinic under the fee-for-service model?
So I moved here in 2017. COVID hit. I was just working all the time. And then I wake up in 2022 and realize that this is my life. But what I realized along the way was that everyone that I interacted with said, hey, do you have an office? Do you have a clinic? Can I come see you again? And I said, no, I'm only here in the hospital. This is what hospitalists do. And they said, you're the only doctor that talked to me that way, and you spent all this extra time with me because I'm notoriously chatty, and people like the bedside manner, the way I train and all this. But the problem was I was sending them out and it was more like fingers crossed that you found a PCP. Good luck. And then you'd mentioned the Merritt Hawkins study talking about just putting numbers to what I had seen in real life was people were not finding a physician after the fact, one that would take their insurance, two that was anywhere near where they lived, and then three, were they even effective in the 7-minute fee for service model? It made no sense to me to continue like that. When I decided to pull the trigger to move to a clinic, it was mostly just to do the traditional fee for service. I said, hey, look, there's a need. I'm seeing these people anyways. I see about 6,000 people a year in these short intervals, and I try to do the best I can. But when they get out, they need somewhere to go, and I could do that. And I said, okay, let's see. I ended up hiring a consulting service to do market research and all this because I didn't have the business training and all this. And and they said, oh yeah, absolutely, you're gonna kill it. This is gonna do well, and there's this huge market. And I got to the point one day when I was reviewing contracts from the insurance companies and things like this, and I said, this doesn't make any sense anymore. That was when I came home and told the wife, I said, we're doing direct primary care. We're going to transition.
And when along your journey did you learn specifically about this business model versus just doing pay me cash for a service, like a one-time visit type of model?
Yeah. So I had never heard of direct primary care. I don't know if you get that a lot. You probably do. But my guess is that I never interacted with a patient who had a direct care primary. I had seen concierge docs before, but in limited interactions and mostly for non-emergent hospital work. Okay. The way I came across it was mostly podcasts. Honestly, just typing in YouTube until the algorithm put me out at a conference or one of these bigger meetings and said, "Hey, you can do something different. You can do a cash pay business," and that's, I guess, where it started.
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. I love it. And I love that there is way more material than there was before so that people can even have the algorithm help them find this model, because there is definitely a lack of state medical societies or county medical societies or even residencies who don't necessarily educate their trainees or their medical students, their fellow doctors, that there actually are other ways to practice medicine, and that doesn't have to be it doesn't have to be attached to 99213 at the end of it. So so I love this. Now, when you shared about how you told your wife, okay, we're doing this, what was the timeline that you had between that conversation and opening day when you opened your doors to patients at Steelman Medical Group?
So we hired a consulting group, like I said, and they were moderately expensive, I would say. It's not a cheap prospect. So I had plans to do something like this, some type of office, for a long time. I would say better part of 3 years or more. And I just knew that I had a skill that was in high demand, and I had the passion to chase it, and I could make this work. I just didn't know the infrastructure until after the work with a consultant group. They said, here's how many people you need to see per day. Here's how much the insurance company is going to pay you per person. Here's how much a Medicare patient will pay you to keep your doors open. And I said, this doesn't add up. I can't, it's not, I've never in my entire career had a 7-minute conversation with a patient. It never will happen. It's just not going to, it's never going to fly. You can't even tell me your history in that time frame. I felt like that. I felt, okay, maybe I just need to do cash pay only and concierge. And I said, I'll just take my patient panel and how much it will cost me to operate this business, and I'll make it a no markup concierge practice. And I'll just see my people, and I'll be very transparent with it. But I didn't know that DPC existed at the time. So when I transitioned, it was about 6 months in to a consulting. Now we're paying them every month and getting back this feedback. And I just came back and I said, I don't care to fight with these guys, to argue I don't have no power. I have no teeth with big insurance. I have no ability to negotiate my rates or to say, what if I want to spend an hour with a patient? It was never going to fly. When I came back and said that, she was on board. We're sitting here with a little baby and getting ready to stop a consistent paycheck in the hospital and go into this full bore. I had planned for this, but it still is a big risk and still a big journey. So
Totally. And people definitely need to know that. Like
Yeah,
that thinking about the finances of doing DPC totally matters. And I think it's one of the most common questions I get from residents and medical
sure,
students is what are you actually able to make in DPC? And so I want to ask there,
sure.
financially, how did you plan for this practice once you found out about DPC?
Planned it one shift at a time. Working hospitalist shifts is all about the shifts. You just can I do an extra shift? Can I do this? So I knew that I was saving for something. I was saving to open a clinic, to open an office, and I didn't. I got to a point where I knew that it was possible based on the market research I had, and my brother turned out to be useful. That he was a commercial real estate broker, so he was my broker in finding a place, and we started interviewing, looking at places, and some of them made sense, others did not. And when we added it all up, I said, I have enough to do this and not have to take out a big loan. I can do a micro practice. My current office is 2 exam rooms and a consult room. This is a fun place to lower your blood pressure and stress level. And it's to my bigger mission in trying to make access a little easier for people. And so far, it's been pretty good. But the office is only 1,200 square feet. I see one patient at a time. I knew that once I transitioned to a DPC structure, that my overhead being as low as possible was absolutely key. So that's what I would do. That's what I would say to anybody, any students or anybody thinking about this is just start with a blank sheet of paper and write out how much do you need to operate on the daily, how much room, what kind of equipment would you want to have, and would you even need a space? Are you going to do tele only? Are you going to, this is the future, so let's deconstruct this thing and paint it the way we want it to be.
It speaks so highly of what we all love about DPC. You know, it's the whole KISS mentality, keep it simple, stupid. We are not stupid, but just that idea of it doesn't have to be
Yeah.
complicated. So when it comes to speaking to budgets, what would you recommend as a reasonable amount of money to have saved up to start your practice?
I don't know that I would push the whole Dave Ramsey thing, but you better have a 3 month emergency fund in there before you can even start to talk about a business plan like that. Um, because it's going to take you that long to build, even if you had the best business plan in the best marketed area you can imagine. One, you just can't onboard people that fast, even if you wanted to. And I'm just talking from somebody creating from scratch without a previous panel. It's going to take a lot of time. So I would say look really tightly at your monthly budget and at least triple that before you could even think about it, and try to have, I don't know, 6 to 9 months of operating costs planned out. That seems like a lot, but it's really not, because my overhead is very little.
I love that advice, especially when it's based off of facts. Look at your own. If you're yes,
Right.
a single person, if you're with a family, it doesn't matter. It's like how much did your electricity cost? How many times did your car go into the shop last year? For us, we do a 6 month emergency fund. Like for our personal family stuff, it's like, okay, how much does it cost for daycare for 6 months? How much does it cost for the amazing no battery when you try to turn on the car situation? You got to go to
Right.
Costco and buy a new battery. Like these things are just simple facts that people can look at their own expenditures. And that's not even starting looking at the business, but that gives you a place to start. And again, I love the idea of just building out that business plan. People like Dr. Amy Ostick and Dr. Brian Ostick at Health and Healing DPC, they did it on the back of a napkin. They're definitely pro Ramsey people. You literally went to doctor school. Like you can do this type of stuff.
Yeah.
So love that. Now, one of the questions I want to ask, because of with this consulting company and with you being in the Woodlands, you're joining the ranks of the amazing doctors who are practicing DPC in the Woodlands area. What was it like? Did you ever think in your journey about joining on to another DPC model or working locums for them versus opening your own clinic?
The truth is, I didn't know they existed. That's so funny, because I saw your interviews with Dr. Snodgrass and a couple others that have been on your podcast before. And I was like, oh my gosh, these people are right here. And I could have just called. It was, I was already 90% done by the time I even realized that there were other folks practicing in my area. It just speaks to the penetration in the market as to how much the general public knows about direct primary care, and how every time I explain this to anyone, they're like, oh my gosh, that makes so much sense. Why do we do it the other way at all? I think that to say this is still starting, this whole direct primary care movement is just, it's just the sunrise. This is going to become the standard of care. There is no question at this point. It's just how quickly will people hear about it? And I'm ready to play my part.
I love it. And you are, because you're sharing your story on this podcast. And just like how you found the YouTube videos, you found the podcast, people also who are physicians in different parts of this country are looking for the same search terms. Like, how do I leave fee-for-service medicine? How do I stop burnout? How do I practice with more time for each patient? These types of things are not foreign to physicians in this day and age. So with that, I wanted to ask you about your day one. When you opened your doors, did you have patients who had found you and wanted to join day one?
I could comment on this because this was a big debate back and forth, right? How to market. This always comes up. And I can vouch for, well, all of 1 week of experience that 100% of my patients through the door so far has been word of mouth. Okay. We did flyers. We have tossed around doing written articles, doing online paid advertising. We, of course, do social media, which is probably the second best thing. I would say word of mouth versus number 2, social media. That just reaches people. And that's how they found me. It wasn't some other trick or circumstance. It was literally, I met a guy who told me about you, who I talked to. And it's like these closed-knit communication circles are just, that's how it's going to happen.
And it just, I'm laughing over here because it's so small town and you're not in a small town, but that's still how networking works. Like it has a small town feel to it, and you're in friggin' Houston. Amazing. So now with you being open, you have your patient, at least your first patient, and you're also with this amazing clinic, you have goals and aspirations for your future. What are you filling your time with when you're not seeing patients? And the reason I ask this is because very frequently people who are in their like 3rd to 5th year of DPC, they're like, man, I miss those days. So what are you filling your time with right now?
Obviously, I have a newborn. She's 14 months. She keeps me as active as I can possibly keep up with. But it's mostly family time. I would say, what do I do when I'm not seeing patients? I'm actually price checking. I'm cold calling pharmacies, compounding pharmacies, different vendors, and trying to negotiate prices down, because that's the biggest part of my building the business is that if I can save you $5 for every interaction with this particular service, I just made my justification for the membership cost that much better. And I'm trying to make it so that as I get better and better deals, I can pass those on to the patients directly. I don't do markups and I don't do anything but transparent costs. When I get it, that's what they see. And I broadcast it as part of my marketing that, hey, look, I just found you an MRI for even cheaper. So we're happy to offer that option. And the vendors actually seek me out directly now.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad. this speaks to being a small business owner, especially like a compounding pharmacy or some mom and pop situation, whatever their business focus is. Cash is still king. Wow, you're paying me
Yeah.
today. We're not on credit. We're not on insurance is going to pay me a year from now. Like you have dollars and I have something to sell you for a dollar amount. So amazing. And I love that especially in Texas where you guys can't self-dispense right now, that's a challenge that is overcome, in different examples of DPC, especially in your area. But it's one of those ways to also build that word of mouth. Like I think about Dr. Leah Gupta and how she would comment on a restaurant's socials and then say, hey, can I come visit you? And then to have a doctor come to your business when you're a non-medical facility or medical facility, and they're like, oh my gosh, you need a doctor. There was this doctor who came in and visited me the other day. Let me give you his information. It's definitely building that awareness in your community. And yes, like you're saying, you didn't necessarily know that there were people around you, but as people continue to learn about it, and we hear this very frequently on the podcast, after a certain amount of patience, there's your marketing strategy. Your word of mouth is amplified by how many number of patients you have or how many people know you exist. So with that, I want to ask about some analytics on your website. Forgive me for if sounding stalkerish here, but like you're on WordPress
Okay.
and
Yeah.
your website, it has not only the listing per age group, you do it by age group, but you also have a button that says, click on this for the listing of full benefits. And so I'm wondering, because like on my website, the FAQ page is a very heavy traffic page because people are like, what is this? And so I'm wondering, do you see that reflected in your analytics? Or where do you see people spending the most time on your page, given that you're new to your community and you're spreading the word about your practice?
Yeah. I would not be necessarily the best source for that data. My wife is practice manager and she runs the show here. She works for the right price. So this was part of the whole deal, was that she would be working with me and doing a lot of the administrative work. But she's told me that benefits page and the fees page where you just get right to it. And those two things are where most people go. In our community, people didn't know what direct care was. They don't understand the model. They don't understand what you do. You'll explain to them for your elevator pitch a few minutes, and then they'll go, "Do you take my insurance?" And you go, "Okay." So that didn't go through. So I just like it. Yes, we take all insurance, but we don't bill them anything. And then I will show you how we save you money directly on each one of the type of services that you might want.
And when you get feedback from your patients who have joined your practice, what is the feedback as to why they joined your practice?
It's super straightforward. People are coming in because of inconsistency or difficulty getting in to see who they were seeing for care. A lot of female patients were getting primary care through their OBGYN, but those OBGYNs are doing other things, obviously, and they have. I'd be scared to even say how long it would be to get an appointment with some of these folks. If your cardiologist was doing your blood pressure management, it's very inconsistent. They tell me that they're having trouble getting their prescriptions filled fast enough. They're having trouble with insurance companies changing the prior authorizations of the formularies. And they have messages sent out to the physician that just go unanswered. So it's an inconsistency. It's the continuity of care is really what people are joining for, just because they didn't know what a primary care physician was because they'd never had one.
I'm rolling my eyes at that out of frustration. And something I shared on the pod before is I had a 20-something patient say, you do pap smears? Are you trained to do that? And I'm like, I'm a family medicine physician, and clearly that does not mean full scope care to most people in this country. Like that is not a thing that people realize that a person in primary care can do. But I love, though, that that's the value proposition that your patients are finding, because that's what they're going to speak to when they speak to their friends and family. It's, oh my gosh, so sorry that you can't get into your person. I can just call Dr. Steelman and get in, because that's the way that his practice works. There's no bells or whistles. It's, I'm a patient, I'm a member, I need an appointment. Boom. I absolutely love that flexibility in our practices to be able to say, like, no, I know you and you don't get sick. So when you're telling me you're experiencing this, like, I'm going to see you ASAP. And you have the time to be able to be flexible. And like now, I do love the fact that for those people who have, like your daughter is 14 months, but who have the young members of their family, that it's not like, hey, wish I could spend time with you, but there's no option. I have to go to work. Like that is the ugly reality of most people in this country when their health insurance is tied to their employment, when they don't have parental time off that's paid, when they are facing other struggles that people in this country with kids experience. So now with your clinic, you're not Dr. Steelman Direct Primary Care, you're Steelman Medical Group. What is the reason you chose Steelman Medical Group with your all of the aspirations that you have now as a person who's left the fee-for-service world?
Sure. I just wanted it to be straightforward in terms of the name. I didn't want it to be kitschy or didn't want to have to pick a symbol or anything like that. It was just, this is pretty straightforward. We didn't really agonize over that decision a long time, but the idea was that I didn't want to pigeon myself into just one scope of this whole thing. I wanted to say, hey, if I can provide a service, if I can navigate for people, let's navigate. Let's be, and that was behind our symbol was a compass. And I said, I can really help direct people almost as much as I can actually write for them. Just writing a prescription is just one part of what I'm doing. So I want really a network of providers to be working with me. So I'm contracting, I'm actively networking with anyone who can provide a medical service in my region. In fact, anywhere in Texas, and in fact, anywhere outside of Texas, because it's 2024 and we are connected instantaneously like this. We have the ability to get questions out there, to get advice from anywhere in the world instantaneously. We don't have to say, oh, you're going to have to go downtown and wait 3 months to get an appointment with some guy you don't know. Let me just tell you about parking. But it's you can do better. You can do more. And they talk about expanding the scope of direct primary care. It's not that I'm expanding the scope of services as much as I'm finding a way to get it done. So, yeah.
Amazing. And that's a driving force behind what you're doing. Not, I have to make this amount of codes to be able to survive next year. Love it. So when you talk about the contracting that's going on, are you partnering with, because you had mentioned prior to the podcast, having interest in bringing people with expertise in personal training, in massage therapy, physical therapy. Are you bringing people on as 1099s, W-2s? How are you partnering with people to have as extensions of Steelman Medical Group?
So the answer is both. It depends on what each provider, each practitioner wants to do. I think everyone has some valuable piece that they can add to the overall service. And I'm one person. I can't be everywhere all the time. But if I find a massage therapist who's really good at lymphatic work, they are solid gold to me. If I can hire them on as a 1099 and pay them a set hourly rate, that's easy. It's just like the locums world that I had so much experience with. I have to help them a little bit with the taxes and explain to them what they got to do in order to make it without hassle. But it's a good way for doctors to get supplemental income, to do consults online. Why not network and provide what you are able to do in your sleep? What I used to say was, my brother lived across the street from me here, and he got my ideal medical care. He could text me anytime, day or night. He would send me a picture of a mole and say, "What is this?" I get a lot of pictures of injuries from the kids across the street and things like that. Just, it works the way DPC is set up, and I think extending that to direct care with specialists, extending that to direct care with ancillary care makes a lot of sense. There's a lot of continuity issues in the big systems and in the insurance world with that too.
Now, when you have people who are joining Stillman Medical Group, with your space having 2 exam rooms and then the consultation room, and with you only seeing one patient at a time, do you share your space with people? Do they have their own spaces? How does that work?
I'm brand new, so you can say I'm flexible. I rarely see one patient in two exam rooms, so I said that two things could be going on at once. But so far, it's just been one at a time. And my intention was that I'm going to be free to participate in some of these interactions altogether. Hey, let's go to physical therapy together. I want to see how good this person is, what they're doing, how effective it really is going to be for you, because I want to capture that network if I can keep that going. My impression in general in trying to do all this, why would I bother? Why not just trust the insurance or whatever? My impression is that a lot of times this gets dropped. They don't call. The patient doesn't know what to do. They don't know the words to even use if they did have a phone number. They need some navigation along with it. And so that's why.
And your logo definitely encompasses that spirit of helping guide people.
It's
Now,
it's a team.
So now with you being an internal medicine physician and then choosing to practice in this model of DPC, did you opt out of Medicare?
Yes. Yes, opting out is the goal. Right now we're awaiting the opportunity to do that. You can only opt out every quarter. Not something I knew originally, but this is the plan. But what we had to do was we had to say, look, the ability to have any kind of income while we're building the practice is severely limited once you're opted out of Medicare. I kid around about doing locum tenens work in New Zealand. If this all doesn't work out, I'm just going to have to leave the country or something. But yeah, that's the plan. We're going to be full into it.
Just because you mentioned New Zealand, if you haven't listened to Dr. Amanda Dornfeld's episode, definitely take a listen to that. She worked in New Zealand for 18 months and happened to be there when the pandemic hit. And so
No.
she was planning her DPC while in New Zealand. Like, it's so amazing what we can do nowadays because of things like the internet and things like networking, but just had to mention that because of the New Zealand connection. So now with you being a doctor who's been in hospital medicine primarily for the most of your career thus far, you're adding things to your practice like aesthetics. When it comes to offering things like aesthetics and your skill set, how did you develop the confidence to say, yes, I'm bringing this skill that I have not necessarily done in the hospital, but I'm a doctor and I can learn things and I can do this in my practice?
That's been a fun adventure. I can tell you. I was just thinking that for Botox, at least, I know that a lot of my neurologist colleagues were doing migraine treatments, different types of injections. But in terms of my getting training for aesthetics, that was also my wife. A lot of ladies in this area, at least, is very popular using botulinum toxin and filler, the hyaluronic acid. So the getting trained in that was fun. Doing it was at least partially selfish because I was paying for it anyways. I might as well learn how to do it and save some money. But it just goes back to having the guts to just dive in there and learn, having the humility to know that you don't have to have a decade of experience to start to learn, as long as you're coming at it with the right attitude, that you really want to do it well and you want to learn from the best. So that's the way I go about it. And I don't see everybody. I don't attempt something that I don't know for absolute sure that I'm not going to do an extraordinarily good job.
But I love that because just hearing you talk there, you're talking about aesthetics in particular, but you literally could have filled that in with opening your own practice as a DPC doctor.
Sure.
Because you're still going at it with the same mindset of who is my ideal person, the person who wants really good care. If you could talk to your former self and your former self was this person who you were in when you were only doing hospitalist medicine, when you were seeing the changes in the healthcare system, when you were feeling that burnout, what would you, now that you've opened, even if it's been a week, you've still opened, what would you say to your former self to educate your former self about this is the future of my life as a doctor, living in America with the way that the healthcare system is right now?
I give this thought on the regular, and I'm so surprised every day walking into that office saying, oh my gosh, this is actually happening. I went from scratch to this, and I have an office and a door and it's just so much to think about. But I would probably say, look, it's okay to not know what exactly you want to do. It's okay to say, I know I want to change. And what I really was begging for, what I was looking for was somebody to have a business plan with numbers in it. You're like, show me the numbers, show me that I can do this, show me, and it doesn't really exist because you are literally making it from the moment you get started with this journey. And at least for me, what it took was breaking it down like a blank sheet of paper. What is it that I'm trying to do? What do I want to get out of this? What am I trying to offer to patients? And literally sell it to yourself. And if it makes sense and it's simple enough, it's an easy enough model, it'll be successful. And I think that's where I stuck.
Thank you so much, Dr. Steelman, for sharing your story today. Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Marielle Concepcion.